In this presentation, we will be discussing common infections. My name is Dr. Juan Mercado. I'm a board-certified family nurse practitioner with clinical expertise in family medicine, sexual health, sexually transmitted infections medicine, and HIV medicine. I received the HIV Clinician Scholar Certificate after completing a year-long training at UIC Midwest States Training and Education Program, and I'm certified in colposcopy and high-resolution endoscopy by the American Society of Cervical Pathology and Colposcopy. I'm also a visiting professor with Chamberlain University. Today I'm going to discuss with you common infections in primary care. We will go over symptoms, differential diagnosis, pathogens, testing, and treatment for the following conditions: cellulitis, impetigo, MRSA, and bites. Cellulitis and erysipelas are two of the most common skin and soft tissue infections. Cellulitis is an acute infection that results from bacterial entry via breaches in the skin barrier. As the bacteria enter the subcutaneous tissues, their toxins are released, which causes an inflammatory response. Cellulitis and erysipelas are almost always a unilateral infection, with the most common site of infection being the lower extremities. Cellulitis involves the deeper dermis and subcutaneous fat. Erysipelas, in contrast, involve the upper dermis, and there is clear demarcation between involved and uninvolved tissue. Cellulitis is observed most frequently among middle-aged individuals and older adults. Erysipelas occur in young children and older adults. Predisposing factors for development of cellulitis and/or skin abscesses include skin barrier disruption due to trauma, skin inflammation, edema due to impaired lymphatic drainage or venous insufficiency, obesity, immunosuppression, such as diabetes or HIV infection, pre-existing skin infection, such as tinea pedis, impetigo, or varicella, immersion injuries, and bites. The vast majority of pathogens associated with cellulitis are from either Streptococcus or Staphylococcus bacteria. The most common are beta-hemolytic streptococci, groups A, B, C, G, and F, and Staphylococcus aureus. Erysipelas results almost always from a group A strep infection. Certain types of injuries or etiologies are associated with more likely pathogens. For example, human bites are associated with Staphylococcus aureus. Dog and cat bites are associated with Pasteurella multocida and Camnotifaga canimorsus. Saltwater exposure is associated with Vibrio fulnificus, and newborns and infants are usually affected by group B strep. Both conditions, erysipelas and cellulitis, manifest with areas of the skin erythema, edema, warmth, and pain. Fever may be present. Additional manifestations of cellulitis and erysipelas include lymphangitis and inflammation of regional lymph nodes. Edema surrounding the hair follicles may lead to dimpling in the skin, creating an appearance reminiscent of an orange peel texture called bout d'orange. Cellulitis may present with or without purulence. Erysipelas is non-purulent. Patients with erysipelas tend to have an acute onset of symptoms with systemic manifestations including fever and chills, whereas patients with cellulitis tend to have a more indolent course with development of localized symptoms over a few days. Many patients with cellulitis have underlying infections such as tinea pedis, lymphedema, and chronic venous insufficiency. In such patients, treatment should be directed at both the infection and the predisposing condition, if modifiable. Erysipelas lesions are raised above the level of surrounding skin with clear demarcation between involved and uninvolved tissue. Classic descriptions of erysipelas note butterfly involvement of the face, involvement of the ear, called Millian's ear sign, is a distinguishing feature for erysipelas, since this region does not contain deeper dermis tissue. The diagnosis of cellulitis in erysipelas is clinical because it is based on physical findings. Although laboratory findings may include leukocytosis and elevated inflammatory markers such as erythrocyte sedimentation rate and C-reactive protein, these are rarely used in the outpatient setting. The differentials should include the following: necrotitis and fasciitis. Necrotitis and fasciitis is a deep infection that results in progressive destruction of the muscle fascia. The affected area may be erythematous, swollen, warm, and exquisitely tender. Pain out of proportion to exam findings may be observed. Toxic shock syndrome. This typically presents with pain that precedes physical findings. Clinical signs of soft tissue infection consist of local swelling and erythema, followed by ecchymosis and sloughing of skin. Fever is common. Gas gangrene. This condition should be suspected in the setting of fever and severe pain in an extremity, particularly in the setting of recent surgery of trauma. Erythema migrans. Erythema migrans, an early manifestation of Lyme disease, manifests as erythema at the site of a tick bite, often with central clearing and a necrotic center. Shingles or herpes zoster. Shingles begins as erythematous papules that evolve into group vesicles. Septic arthritis. Cellulitis may overlie a septic joint. Clinical manifestations include joint pain, swelling, warmth, and limited range of motion. Contact dermatitis. In contrast with cellulitis, contact dermatitis is always pruritic. Vasculitis. Macular and papular lesions of vasculitis are non-blanchable due to the presence of extravasated erythrocytes in the dermis. Insect bite. An insect bite consists of pruritic local erythema and edema. Vaccination site reaction. This is local reaction that is manifested with erythema, swelling, and tenderness at the injection site. And stasis dermatitis. This is an inflammatory dermatosis of the lower extremities that occurs in patients with chronic venous insufficiency, and it tends to be extremely pruritic. Patients with cellulitis or erysipelas, in the absence of abscesses or purulent drainage, should be managed with empiric antibiotic therapy. Patients with drainable abscesses should undergo incision and drainage. Patients with mild infection may be treated with oral antibiotics. In contrast, patients with systemic signs of toxicity should be admitted to receive parenteral therapy. Systemic symptoms include the following: fever over 100.5, hypotension with sustained tachycardia, rapid progression of erythema, progression of clinical findings after 48 hours of oral antibiotic therapy, inability to tolerate oral therapy, and proximity of the lesion to an indwelling medical device, such as prosthetic joint or vascular graft. Patients with erysipelas should be managed with empirical therapy for infection due to beta-hemolytic streptococci, which penicillin V potassium 500 mg oral every 6 hours, or amoxicillin 875 mg twice a day, cephalexin 500 mg 4 times daily. This is the alternative for mild penicillin allergy. And for severe penicillin allergy, the alternative is clindamycin 300 mg to 400 mg 4 times daily. Patients with cellulitis should be managed with empirical therapy for infection due to beta-hemolytic streptococci and methicillin-susceptible Staphylococcus aureus, MRSA, with cephalexin 500 mg 4 times daily, or clindamycin 300 to 450 mg 4 times daily. Coverage for MRSA should be added in the following circumstances: systemic signs of toxicity, such as fever over 100.5 degrees, prior episodes of MRSA infection or non-MRSA colonization, lack of clinical response to antibiotic regimen that does not include activity against MRSA, presence of risk factors for MRSA infections such as recent hospitalization, residence in a long-term care facility, recent surgery, hemodialysis, and HIV infection. Proximity of the lesion to an indwelling medical device is another risk factor for MRSA. The coverage for MRSA is achieved by adding to amoxicillin one of the following: Bactrim double strength twice daily, doxycycline 100 mg twice daily, minocycline 200 mg once daily, then 100 mg orally every 12 hours, or clindamycin. If clindamycin is used, no additional MRSA coverage is needed. A deepening of erythema may be observed following initiation of antimicrobial therapy. This is caused by destruction of pathogens that release enzymes, increasing local inflammation, and should not be mistaken for therapeutic failure. Patients with cellulitis typically have symptomatic improvement within 24 to 48 hours of beginning antimicrobial therapy. The duration of therapy should be individualized depending on clinical response. In general, 5 days of therapy is appropriate for patients with uncomplicated cellulitis whose infection has improved within this time period. Let's move on now and talk about impetigo. Impetigo is a superficial bacterial infection of the skin. It's classified into primary impetigo when there is a direct bacterial invasion of previously normal skin, or secondary impetigo when the infection arises outside of minor skin trauma. The occurrence of secondary impetigo is referred to as impetiginization. Impetigo is most frequently observed in children ages 2 to 5 years of age, although older children of any age and adults may also be affected. The infection usually occurs in warm, humid conditions and is easily spread among individuals in close contact. Risk factors include poverty, crowding, poor hygiene, and underlying scabies. Impetigo is primarily caused by Staphylococcus aureus. Group A Streptococcus gas causes a minority of cases, either alone or in combination with S. aureus. Occasionally, MRSA is detected in some cases of impetigo. Variants of impetigo include non-bolus impetigo, bolus impetigo, and ecthyma. Non-bolus impetigo is the most common form of impetigo. It begins as papules that progress to vesicles surrounded by erythema. Within a week, the papules eventually become pustules that enlarge, break down, and form thick, adherent crust with a characteristic golden appearance. Lesions usually involve the face and extremities. Regional lymphadenitis may occur, although systemic symptoms are usually absent. Bolus impetigo is seen primarily in young children in which the vesicles enlarge to form flaccid bullae with clear yellow fluid, which later becomes darker in ruptures, leaving a thin brown crust. The trunk is more frequently affected. Bolus impetigo in an adult with appropriate demographic risk factors should prompt an investigation for previously undiagnosed human immunodeficiency virus infection. Ecthyma is caused by group A beta hemolytic streptococcus, or Streptococcus pyogenes. This consists of an ulcerative form in which the lesion extends through the epidermis and deep into the dermis. Ecthyma resembles punched-out ulcers covered with yellow crust surrounded by raised violations margins. Post-streptococcal glomerulonephritis is a serious complication of impetigo, ecthyma precisely. This condition develops within 1 to 2 weeks following infection. Post-streptococcal glomerulonephritis manifests with edema, hypertension, fever, and hematuria. The diagnosis of impetigo often can be made on the basis of clinical manifestations. A gram stain and culture of pus or exudate is recommended to identify whether Staphylococcus aureus and/or beta hemolytic streptococcus is the cause. However, treatment may be initiated without these studies in patients with typical clinical presentations. Differential diagnosis for impetigo should include skin conditions that share features with non-bolus impetigo, such as contact dermatitis, tinea infection, eczema herpeticum, and herpes simplex virus infections. Bolus impetigo should be differentiated from pemphigus vulgaris, acute contact dermatitis, bullous drug eruptions, burns, and bullous insect bite reactions. Bolus and non-bolus impetigo can be treated with either topical or oral therapy. Topical therapy is used for patients with limited skin involvement, whereas oral therapy is recommended for patients with numerous lesions. Unlike impetigo, ecthyma should always be treated with oral therapy. Benefits of topical therapy include fewer side effects and lower risk for contributing to bacterial resistance compared with oral therapy. Topical choices to treat impetigo include the following medications for 5 days: Mupirocin 3 times daily, riptopamilin twice daily. Extensive impetigo and ecthyma should be treated with an antibiotic effective for both Staphylococcus aureus and Streptococcus infections unless cultures reveal only streptococci. Dicloxazoline and cephalexin are appropriate treatments. A 7-day course of oral antibiotic treatment is recommended. If only streptococci are detected in extensive impetigo or ecthyma, oral penicillin is the preferred therapy. MRSA impetigo can be treated with doxycycline, clindamycin, or Bactrim. Crusted lesions can be washed gently. Children can return to school 24 hours after beginning an effective antimicrobial therapy. Draining lesions should be kept covered. Infections with methicillin-resistant Staphylococcus aureus, or MRSA, as the name indicates, are those caused by strains of Staphylococcus aureus that developed a resistance to methicillin shortly after the introduction of this medication in England in 1961. Methicillin resistance is mediated by a penicillin-binding protein that permits the organism to grow and divide in the presence of methicillin and other beta-lactam antibiotics. Risk factors for community-associated methicillin-resistant Staphylococcus aureus, CA-MRSA or CA-MRSA, include the following. Antibiotic use secondary to antibiotic selective pressure. Use of cephalosporins and fluoroquinolones strongly correlates with the risk of MRSA colonization and infection. HIV infection, hemodialysis, and long-term care facility. CA-MRSA strains are most commonly transmitted by direct contact with a colonized or infected individual. CA-MRSA can also be acquired by contact with contaminated fomites used by an infected individual. Individuals colonized with MRSA serve as a reservoir for transmission. MRSA can colonize the skin and ears of hospitalized patients, healthcare workers, and healthy individuals. Colonization can occur from inhalation of aerosolized droplets from chronic nasal carriers. CA-MRSA isolates are most often associated with skin and soft tissue infections. Common signs and symptoms of MRSA infections include the development of a skin abscess, which is defined as a collection of pus within the dermis or subcutaneous space. It manifests as a painful, fluctuant, erythematous nodule with or without surrounding cellulitis. Spontaneous drainage of purulent material may occur. Regional adenopathy may be observed. But fever, chills, and systemic toxicity are unusual. CA-MRSA can also manifest as furuncles, abscessed hair follicles or boils, and carbuncles, coalesced masses of furuncles. The diagnosis of a skin abscess is usually based upon clinical manifestations. Laboratory testing is not required for patients with uncomplicated infection in the absence of comorbidities or complications. Patients with drainable abscesses should undergo incision and drainage with culture and susceptibility testing of the branded material. Blood culture should be obtained prior to the initiation of antibiotic therapy when the lesion is secondary to animal bites or water-associated injuries. Differential should include the following. Epidermoid cyst, a skin-colored cutaneous nodule, often with a central puncture that is freely movable on palpation. Epidermoid cyst, however, may become secondarily infected. Folliculitis, defined as the inflammation of one or more hair follicles. Hidradenitis suppurativa, a chronic suppurative process involving the skin and subcutaneous tissue of the intertriginous skin, and recluse spider bites. However, CA-MRSA infections are far more prevalent than spider bites. Patients with drainable abscesses should undergo incision and drainage. For patients undergoing incision and drainage of a skin abscess, some experts suggest antibiotic treatment under some conditions. The conditions are a single abscess more or equal to 2 centimeters, or multiple lesions, extensive surrounding cellulitis, associated immunosuppression or other comorbidities, systemic signs of toxicity, the presence of an indwelling medical device, high risk for transmission of Staphylococcus aureus to others, such as in athletes or military personnel. Antibiotics with coverage for CA-MRSA include the following: Bactrim, double strength, twice daily; doxycycline, 100 milligrams, twice daily; minocycline, 200 milligrams orally once, then 100 milligrams orally every 12 hours, and clindamycin, 300 to 450 milligrams 4 times daily. Treatment should be offered for at least 5 days. A beta-lactam drug should be added if the access is perioral or perirectal. Soft tissue trauma caused by animal and human bites have serious clinical implications because of the potential for complications. Animal bites are more common among children than among adults. Dog bites can cause a range of injuries from minor to major complicated wounds. The extremities, particularly the dominant hand, are the most frequent site of injury in older children or adults. The predominant pathogen in animal bite wounds are the oral flora of the biting animal and human skin flora. Therefore, infection usually results from a mixture of organisms. Common pathogens of a dog bite include Pasteurella, Staphylococcus, Streptococcus species, and Capnocytophaga canimorsus. Clinical significant in splenic patients, chronic alcohol abusers, and those with underlying hepatic disease. About 2/3 of cat bites involve the upper extremities. The puncture wounds are of particular concern because cats have long, slender, sharp teeth. Cat bites can transmit Pasteurella and Bartonella hensel. With human bites, semicircular or oval area of erythema or bruising is usually visible. The skin itself may or may not be intact. Bites by humans occur in 2 basic categories. Occlusive wounds, more common in females, with teeth closing over and breaking the skin. And clenched fist or fight bites, more common in males, in which the skin surface, usually of the hand, strikes a tooth, resulting in damage to the skin and underlying structures. Organisms recovered from human bites include Echinella corrodens and Group A Streptococcus. Clenched fist injuries consist of skin breaks over the knuckles. The lacerations typically occur over the 3rd and 4th metacarpophalangeal or proximal interphalangeal joints of the dominant hand. Clinical manifestations of bite wounds infections may include fever, erythema, swelling, tenderness, purulent drainage, and lymphangitis. Infection with Pasteurella multocida characteristically develops rapidly following cat or dog bites with erythema, swelling, and intense pain, evident as early as 12 to 24 hours after the bite. Aerobic and anaerobic blood cultures are warranted prior to antibiotic therapy in patients with an infected bite wound and signs of systemic infection. Wound cultures of uninfected bite wounds are not useful. Wound cultures are not indicated in clinically uninfected bite wounds as results do not correlate with likelihood of infection or the pathogen that is present in patients with subsequent infection. If a bite wound appears to be infected, gram-stained and anaerobic cultures should be obtained prior to the initiation of antibiotics. The laboratory requisition should note that an animal or wound bite wound is the culture source because Echinella corrodens and Pasteurella multocida are fastidious organisms. The list of differential diagnosis of bites is limited because of the evident history of trauma. However, in cases when no history can be elicited, cellulitis and insect bites are appropriate differential diagnoses. Bite wounds should be irrigated copiously with sterile saline, and grossly visible debris should be removed. Prophylactic antibiotics are administered to patients who present for evaluation of a bite wound who do not yet have signs and symptoms of infection in the following circumstances: deep puncture wounds, especially due to cat bites, wounds requiring surgical repair, moderate to severe wounds with associated crush injury, wounds in areas of underlying venous and/or lymphatic compromise, wounds of the hands or in close proximity to a bone or joint, wounds on the face or in the genital area, and wounds in immunocompromised holes. Amoxicillin clavulanate 875 mg / 125 mg twice daily is the agent of choice. Alternative antibiotics include one of the following agents with activity against Pasteurella: doxycycline 100 mg twice daily, Bactrim double strength twice daily, penicillin VK 500 mg 4 times daily, or ciprofloxacin 500 mg twice daily, plus one of the following agents with anaerobic activity: metronidazole 500 mg 3 times daily, or clindamycin 450 mg 3 times daily. First-generation cephalosporin and macrolides should be avoided. The duration of prophylactic oral antibiotics is 3 to 5 days with close follow-up. Tetanus toxoid should be given to those who have completed a primary immunization series but who received the most recent booster 5 or more years ago. Patients with mild infection can be treated initially with the same prophylactic antibiotics for 5 to 14 days of therapy.